I can tell you that I have seen many diagnosis error being made. And this is an important point, especially for young people, because when we begin, we have the enthusiasm for surgery, and sometimes this will lead us to mistakes. Look at this. This was a woman that with this MRI was operated and underwent arthroscopical decompression by her surgeon, and she did not get well. 2 years later, he went back to her surgeon, and having this MRI, his surgeon told her, "You need now an open surgery, so let's wait." And this woman was a very good patient. She waited for 2 years more, and I received her 4 years later after the arthroscopic surgery. And in fact, what she had was a tuberculous osteoarthritis. So sometimes things can look like one pathology, but in fact are something completely different. This was a 55 years old patient with shoulder pain for 1 year. When I received him, he had gone through 2 arthroscopic subacromial decompressions, but he continued with severe pain and with a situation that we must have be like a red flag for us, because the pattern of pain was not the usual for subacromial impingement or a tendinopathy of the rotator cuff. And in fact, what he had was a lung cancer metastasis that was located in the subacromial space. You can see it here. Very strange case. But these cases are common. I could show you many cases that I have collected during the last 30 years, let's say. This is another case to finish speaking about diagnosis, a 67 years old patient with shoulder pain for 1 year. He came with this MRI saying, "I have a rotator cuff partial tear. I have visited 3 surgeons. 2 told me that I should go through an arthroscopic surgery, and 1 told me that I am a candidate for an open procedure. What should I do, open or arthroscopic?" But I did not look only at the rotator cuff. I watched the humeral head. There was a strange image there, and this is a problem. These patients many times have only an MRI, or even worse, now we are getting fan of the ultrasound performed by the orthopedic surgeon at the office of the orthopedic surgeon. But many times there are things going on in the humeral head. And I asked this patient an X-ray, I asked a scintigraphy, and in fact, this patient had a prostate cancer metastasis, and he was going to be operated of a partial rotator cuff tear. So in these cases, if conservative treatment would have done in a very good way, could have had some options, some possibilities to calm down the pain, but especially to give us the chance to examine the patient a second or a third time and realize that something different was going on. It is a bad idea to go directly to surgery in these cases. Another thing that I have seen is that conservative treatment many times have been underestimated and wasted. Unfortunately, I trained with Dr. Rockwood, and I know the importance of the conservative treatment. So there are many things published that shows this. For instance, these were 104 patients that were operated because of a subacromial impingement, and as you can see here, 50% of them were direct to surgery and did not receive any kind of previous exercise program. Again, it is important in those patients in which it's possible to obtain a good result with conservative treatment, to perform the conservative treatment, and the surgeon must be involved in this treatment and must know about this treatment. A third thing that I have seen is that there is a great variability in therapeutic decision making amongst different surgeons. And this is already published in this paper. There were more than 300 surgeons responding, and it was shown that there was a significant variability in decision making and a lack of clinical concordance. Also, in this paper, they analyzed the indications for repair of the rotator cuff, and most of the studies did not describe the reason for the surgical indication. So there is a problem for us that I know there are so many variables about the lesion, about the patient, that it is difficult to have a uniform decision-making prognosis. But there are also geographic variations. And you can see here, even in the same country, in Mississippi, they operate 9 patients every 100,000 population. In Michigan, 27, and Idaho, 65. Why? Well, there are many reasons for this. And sometimes the reasons are related to the different codes, administrative reasons that are applied to pay the surgeries. So the surgical rates have many conditionants that they are not always, and many biases that they are not always discussed as they should, because this is part of the problem. I have also seen the peak and decline of acromioplasty. In the 90s, I'm sure Dr. Juan Carlos Gonzalez as well, we have performed many acromioplasties, but as you can see here, from 1996 to 2006, there was an important rise of acromioplasties. But as you can see in this other paper, after 2006, there is a decline of the number of procedures, especially after Dr. Madsen's paper, and I'm sure that Juan Carlos, who know very well Dr. Madsen, will have something to say about this. I have also seen many advances and contradictions in surgical techniques. And the first surgery in which I participate was a surgery done by my father 40 years ago. I was a medical student, and he performed the McLaughlin technique, and he proceeded with an osteotomy of the lateral acromion. We repaired, it was an acute rotator cuff tear. It was a sailor. And after that, we put the patient in this kind of plaster for 6 weeks. After that, that lateral acromiectomy that we perform in the last 40 years, I have seen that after that near imposed the anteroinferior acromioplasty. But then Rockwood said, no, it is better to do it in 2 steps. Then we have the arthroscopic acromioplasty, and then they told us, you shouldn't do acromioplasty. What about and now we are going to the lateral acromioplasty again. So it is interesting how things have come and go. Again, with the acromioclavicular, with the acromiocoracoid ligament, we used to resect it. Then they said, do not resect the coracoacromial ligament. The repair was at the beginning transosseous. Then it was better to use anchors, titanium anchors, then resorbable anchors. Then we went to PIC anchors. We discussed single row, double row, suture bridge, arthroscopic transosseous repair. So we went back to the transosseous system after going through many different techniques. Rockwood used to advise the use of debridement. Then when the repair was not possible, then they told us that latissimo dorsi transfer is the best way. Now we are talking about, sorry, lower trapezius transfer. We have balloon spacer, superior capsular reconstruction, reverse arthroplasty. So you can see in 40 years how many options, and some of them are opposite options. What is going to be the future? What the future is going to bring us? We don't know. I have seen in these 40 years the same person saying, I have never seen a rotator cuff that I cannot repair, and several years later saying we should perform the superior capsular reconstruction. So it was not that like what he said in the beginning. So it is difficult to find something clear or uniform, seeing the things from a point of view of 40 years. If you compare McLaughlin procedure 1944 and Burkhardt procedure 2003, besides the approach, there are not big difference in the repair. And many years went from one procedure to the second one, but there are not big differences. Uh, Even more, we keep on discussing which are the advantages of the arthroscopy. We know that there are many advantages, but clinically, if we consider the follow-up, this paper was published by George Atwell last year, 2019. He did not find big differences on function, pain, and range of motion comparing open to arthroscopic repair. In fact, I think that we have tried to conceal with surgical gestures our inability to provide a biological solution. Because here, the protagonist is the tendon, is not the repair. And unfortunately for us, orthopedic surgeons, we have made the technical procedure the star of this movie. And speaking about movies, sometimes I feel that we were doing this. I don't know if you all remember this movie. That was a very fun movie about a guy that you can see him in the middle that was dead, and his friends were taking him on holidays everywhere, but he was already dead. And sometimes we did the same with the rotator cuff. The tendon was dead, and we were playing to how to repair that, but we were repairing a dead tissue. I think that there are some concepts that were misunderstood. One thing is reparability, another thing is biological responsiveness, and another is functional ability. Reparability was related to the amount of retraction and the humeral acromion distance. But you can see patients like this one with a big retraction, you can see here, and with a very short acromio-humeral distance, and it was possible to put back the rotator cuff in its point, in the place it should be. The same patient, another case, the X-ray shows a good acromio-humeral distance, but you can see here that the MRI shows something completely different. So it is sometimes difficult to find a reliable prognostic factor. I think that the point is also the biological responsiveness. If I can repair a tendon, but the tendon cannot respond and not heal, it will be not necessary to repair it. And there are not many classifications evaluating the quality, the biological quality of the tendon. This is a nice one by Riley, and he says that in grade 4, when we have severe degeneration, the tendon will never heal. So to make things even more complicated, there is not a correlation between the type or the size of the injury, of the tear, and the characteristics of the tissue. So we cannot extrapolate what we see on the MRI to the biological responsiveness. Finally, we should talk about the functional ability, and we consider the atrophy of the muscle belly and the infiltration, the fat infiltration described by Goutalier. But there are some papers that have studied the amount of fat in the muscle belly, and they do not correlate with we see on the MRIs. I have also seen the development of diagnostic methods that allow us to understand much better the problem we face, and those are good news. Now we have options that for sure will be developed in the future that will give us not only information about the size of the tear, but also the quality of the tendon. And that is going to be very important for us for decision making. I have also seen the advent of new reconstructive techniques when the calf cannot be repaired, and you know all of them, and I think that are very interesting, but we must consider that they are not always necessary. And this paper by Alexander Lederman, is very interesting, that there is no evidence to show that latissimu dorsi transfer in type E choline rotator cuff tears is better than a partial repair. So sometimes it's not necessary to put the patients through a very complicated and big surgery, and especially unpredictable result when we have perhaps to begin to the chance to perform a surgery that is not so complicated. This patient was a 70 years old woman that was referred to me with a pseudoparalytic arm and indication of reverse arthroplasty, but was just a matter of calming her pain, putting down her pain, and rehab program at home, and she completely recovered the movement with no pain. So again, there is always time to go to surgery when it is not an acute tear. I have also seen the advent of regenerative techniques, and we all know about that. They are in the market and they are growing every day. There were serious studies about this, like this one by Rodeo, but there are also many things going on. And for instance, the Dr. Bill Malone from the JSES warned that the clinical data is limited, and many treatments are still unproven. This is a patient, 71 years old patient, a doctor that has some very mild pain when playing tennis, and he received the advice of having a PRP shot on his shoulder, and just with one, he got septic osteoarthritis, and now he cannot move his arm. So we must be very serious, because it's very easy to make the decision when it is not our own shoulder. I have also seen many techniques imposed by commercial pressures in these 40 years, especially in the last 15 years. And as Juan Carlos Gonzalez says, rotator cuff repair is one of the best examples of planned obsolescence. And we should be very careful about that. I have also, to finish, seen many colleagues who, beyond any commercial interest, have sought the truth and the best way to treat their patients. And I want to give a tribute to Dr. Rockwood, that I know very well, and the colleagues that are sharing with us this session today. Thank you very much.